Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast for the February 2025 issue of the journal Chest. We have a great lineup of diverse content in this month's issue. Over the next 15 minutes, I'll provide a brief overview of key manuscripts published in each of our content areas. First, our asthma content area includes a research letter that evaluates ethnic variation in asthma prevalence across childhood in the Asian American and Pacific Islander population, and a How I Do It review on choosing the right biologic for the right patient with severe asthma. Next is our chest infections content area. Metagenomic next-generation sequencing is a method to increase the pathogen identification rate in patients with severe community-acquired pneumonia. The impact of metagenomic next-generation sequencing on clinical outcomes is not clear. In this issue, Wu and colleagues report findings from a multi-center, randomized controlled, open-label clinical trial conducted on 349 patients in 10 intensive care units that was designed to determine the impact of metagenomic next-generation sequencing of BAL fluid in patients with severe community-acquired pneumonia on their clinical outcomes, including the primary outcome of time to clinical improvement. The time to clinical improvement was shorter in the metagenomic next-generation sequencing group than in the conventional microbiologic test group at 10 versus 13 days. The proportion of patients with clinical improvement within 14 days was also higher in the metagenomic next-generation sequencing group at 62% versus 46.5%. These findings show that the addition of metagenomic next-generation sequencing to conventional microbiologic tests leads to a reduced time to clinical improvement in patients with severe community-acquired pneumonia. Also in this section is an original research article that evaluates the impact of cystic fibrosis transmembrane conductance regulator modulators on maternal outcomes during and after pregnancy, and a chest review on the diagnosis and prevention of invasive fungal infections in the immunocompromised host. Our COPD content area is next. The impact of ensifentrine, a novel first-in-class selective dual inhibitor of phosphodiesterase 3 and 4 on the rate of COPD exacerbations is not known. In this issue, Skirba and colleagues report findings from a pre-specified pooled analysis of two phase 3 clinical trials, the ENHANCE-1 and ENHANCE-2 trials, to determine the effect of ensifentrine at 3 milligrams 3 times a day over 24 weeks on exacerbation rate and exacerbation risk in 1,549 patients aged 40 to 80 with moderate to severe COPD. Ensifentrine was associated with significant reductions in the rate at a rate ratio of 0.59 and risk, the hazard ratio of 0.59 of moderate to severe exacerbations when compared to placebo. These findings were consistent across all subgroups. These findings show that ensifentrine can reduce the rate of exacerbations and increase the time to first exacerbation among patients with moderate to severe COPD. Other original research appearing in this section include a comparison of gold and star severity stages in individuals with COPD undergoing pulmonary rehabilitation, an assessment of the relationship between pulmonary vascular structure and function with exercise capacity in health and COPD, an evaluation of the implications of GLI spirometry reference equations in Northeast Asian patients with COPD, and a description of inpatient complication rates of bronchoscopic lung volume reduction in the United States. Completing this section is a chest review of editing approaches to treat alpha-1 antitrypsin deficiency. Next is our critical care content area. The physiologic effects of different ventilation strategies on patients with ARDS requires clarification. In this issue, Zhang and colleagues report findings from a single-center, randomized controlled trial of 40 patients with moderate to severe ARDS, designed to determine whether airway pressure release ventilation improves lung ventilation perfusion matching and ventilation homogeneity compared to low tidal volume ventilation. Patients receiving APRV showed significant increases in dorsal ventilation, decreased dorsal shunt, and increased dorsal ventilation perfusion matching compared to those receiving low tidal volume ventilation. Ventilation distribution heterogeneity decreased in the APRV group and increased in the low tidal volume group. Those in the APRV group had higher PaO2 to FiO2 ratios and respiratory system static compliance, and lower PaCO2 at 24 hours. These findings show that APRV could recruit the dorsal region, reduce dorsal shunt, increase dorsal ventilation perfusion matching, and improve ventilation homogeneity, leading to better gas exchange and compliance in patients with moderate to severe ARDS. Also in this section is an observational single-center cohort study exploring strategies for coping with complicated grief in relatives of critically ill patients, and a prospective study evaluating the influence of patient position on non-invasive arterial pressure measurements at the lower leg. Completing this section is a chest guideline on red blood cell transfusion in critically ill adults. On to our diffuse lung disease content area. Environmental exposures may contribute to disease onset in sarcoidosis. It is unclear whether these exposures are associated with disease outcomes. In this issue, Mustafa et al. Present findings from a retrospective cross-sectional study of 415 patients with pulmonary sarcoidosis designed to determine if higher exposure to PM2.5 and nitrogen dioxide is associated with worse lung function in those with sarcoidosis. In this study cohort, higher exposure to PM2.5 and nitrogen dioxide were associated with lower DLCO % predicted. There were no associations between these exposures and FVC or FEV1 % predicted. Black individuals had significantly higher exposure to PM2.5 and nitrogen dioxide compared to non-Hispanic white individuals. These findings connect higher exposure to PM2.5 and nitrogen dioxide with worse DLCO % predicted and suggest a connection between air pollution exposure and health disparities in sarcoidosis. Also in this section is an original research article that evaluates airway abnormalities in a prospective cohort of patients with rheumatoid arthritis and a propensity-matched analysis of single versus double lung transplant in older adults. Completing this section is a chest review of the recognition and management of diffuse cystic lung disease. On to our education and clinical practice content area. It is unclear whether preserved ratio impaired spirometry and restrictive spirometric patterns have different associated risk factors, morbidity, and mortality. In this issue, Sestelli and colleagues present findings from a cross-sectional and longitudinal study of over 26,000 Norwegian general population men aged 30 to 46, designed to identify associations between PRISM and restrictive spirometric patterns with clinical and pulmonary function variables. PRISM was identified in 1.4% of the population, restrictive spirometric patterns alone in 1.7%, and the two together in 3.5%. Those with PRISM alone were frequently obese, had a tobacco use history, and reported coughing, sputum production, wheezing, asthma, and bronchitis. Those with restrictive spirometric patterns alone had breathlessness, and some were obese while others underweight. Restrictive spirometric patterns alone had increased all-cause, cardiovascular, and cancer-related mortality compared to those with normal spirometry. PRISM alone had increased respiratory disease mortality, and those with the two together had intermediate characteristics as well as the poorest prognosis. These results suggest that those with PRISM and restrictive spirometric patterns have distinct risk factors, morbidity, and mortality, which could help with future study designs. Our pulmonary vascular content area is next. Post-pulmonary embolism dyspnea is common. It is unclear if those with post-pulmonary embolism dyspnea have unique physiologic phenotypes. In this issue, Incel and colleagues evaluate 173 patients at the time of an acute PE, 67 of whom underwent invasive cardiopulmonary testing, to determine if distinct post-PE dyspnea physiologic phenotypes exist. All patients had reductions in peak VO2 and peak cardiac index relative to control participants. 3 clusters were identified. Cluster 1 had elevated right ventricular afterload and impaired ventilatory efficiency. Cluster 2, elevated right ventricular afterload with reductions in respiratory mechanics. And cluster 3, mild derangements in RV afterload with mild reductions in peak cardiac output. These findings revealed significant heterogeneity in post-pulmonary embolism dyspnea, with 3 phenotypes characterized by differences in right ventricular afterload, ventilatory efficiency, respiratory mechanics, and peripheral oxygen use. Also in this section is a study of the prognostic relevance of the TAPSE to systolic pulmonary arterial pressure ratio and its association with exercise hemodynamics in patients with normal or mildly elevated resting pulmonary artery pressure, and a post hoc analysis of the PREVENT trial that reports the performance of risk assessment models for venous thromboembolism in critically ill patients receiving pharmacologic thromboprophylaxis. On to our sleep medicine content area. Oronasal CPAP is associated with lower effectiveness and lower adherence than nasal CPAP. In this issue, Xavier and colleagues evaluated 20 patients with obstructive sleep apnea who were receiving oronasal CPAP with 3 different CPAP polysomnogram titrations, one with both the nasal and oral compartment open, another with only the oral compartment open, and a third with a nasal alone mask. The study was designed to determine the impact of the oral route and of lateral positioning in patients well adapted to oral nasal CPAP, and to determine whether it was possible to switch those receiving oral nasal CPAP to nasal CPAP. Oral CPAP was less effective than oral nasal CPAP, as represented by a higher residual apnea-hypopnea index, despite a higher CPAP level. The residual AHI was lower in the lateral position for both oronasal and oral CPAP. 75% of patients agreed to change to and preferred continuing use of a nasal mask, resulting in lower CPAP levels and better sleep apnea control. These findings show a reduced effectiveness of oronasal CPAP without the nasal route, improved efficacy of oronasal CPAP in the lateral position, and improved effectiveness upon transition to a nasal mask. Next is our thoracic oncology content area. barriers to healthcare access may lead to tobacco-related disparities that could be overcome by the use of mobile technologies. In this issue, Cartojano Barrera and colleagues report findings from a 2-arm parallel group randomized clinical trial that included 457 Latino adults who smoke, designed to determine if Decide-Text2, a culturally accommodated mobile health intervention, is more effective for smoking cessation and standard care among Latinx adults who smoke. When those lost to follow-up were treated as if they were continuing to smoke, 14.4% of participants in the intervention group and 9.2% in the standard care group were verified as being abstinent from smoking at week 24, and 34.1% versus 20.6% at self-reported smoking abstinence. In those who completed the week 24 assessment, 90.6% in the intervention group reported using nicotine replacement therapy at least once, compared to 72% in the standard care group. These findings showed that this mobile health intervention was able to increase self-reported smoking abstinence and the uptake of nicotine replacement therapy, encouraging the use of this mobile intervention for smoking cessation in Latino adults. Completing this section is a research letter that explores healthcare provider practices and perceptions of biomarker testing in U.S. veterans with non-small cell lung cancer. I encourage you to read our Humanities in Chest Medicine section, where you'll find an original research article that evaluates the perspectives of clinicians on the value of the Get to Know Me board in the intensive care unit, an Advantage article on critical care psychiatry, as well as our commentary series, where you'll find thoughtful pieces on the politicization of menthol cigarette bans in the United States and the need for a strict definition of diagnostic yield and patient-centered study designs in the evaluation of advanced bronchoscopy procedures. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope that you enjoy reading all of the content available in this month's issue of Chest. As always, I'm very grateful to the authors of this work, the reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope you enjoy the February issue.
Thanks for listening to the Chest Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original Chest Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.